Have you ever felt that, that nagging digestive discomfort after maybe a glass of milk and immediately thought, lactose intolerance?
Oh, definitely.
It's a really common assumption, right? And often we kind of end up lumping together completely different reactions to dairy products. Welcome to the deep dive, where today we're really going on a mission to untangle two very common yet really distinct adverse food reactions to milk.
Yeah.
Lactose intolerance and cow's milk allergy.
Yeah.
We pulled together a whole stack of fascinating research papers, clinical reviews, to give you the most important nuggets of knowledge on this.
And you're hitting on something vital there, because while the symptoms, they can feel incredibly similar on the surface.
Right.
Understanding the underlying mechanisms, what's actually happening inside, that's absolutely crucial. And this knowledge, it isn't just academic theory, it's really the key to getting a proper diagnosis, proper management, and preventing those unnecessary dietary restrictions or, missteps that could really impact your health, especially for kids.
That's exactly our goal for you today. By the end of this deep dive, you'll know precisely what's happening in your body with each condition, how to tell them apart, and, most importantly, what to do about it if you or someone you know is experiencing symptoms. Okay, let's unpack this. So let's start at the absolute bedrock difference, okay? Because adverse food reactions, let's call them AFRs.
Yep.
They're primarily classified by how they happen in your body.
Exactly.
This is where the confusion often starts, but also where we can find some real clarity.
Precisely. So think of AFRs like two big buckets, right? One bucket is immune-mediated. That's where your food allergies live, like cow's milk allergy.
Gotcha. Yeah.
The other bucket is non-immune-mediated, and that's where food intolerances fit in, like lactose intolerance.
Okay.
So lactose intolerance, or LI, it's a non-immune-mediated food intolerance. It happens because there's basically reduced activity of the lactase enzyme in your small bowel. That enzyme is supposed to break down lactose, which is a sugar. If it's not working well, that sugar isn't properly digested. Simple as that, mechanically.
Okay, so that's LH. What about cow's milk allergy then?
Now, cow's milk allergy, or CMA, that's an immune-mediated food allergy. And here's the critical difference.
Yeah.
It's specifically triggered by milk proteins.
So LI is about a sugar lactose. CMA is about a protein.
Exactly.
That sounds like a simple difference on the surface, but I guess this distinction is actually the key to why managing them is so different.
It absolutely is.
And why getting it wrong could have, major health consequences. This really feels like the core insight of our deep dive today.
It really is. And, it gets even more nuanced with CMA because the immune system can react in a couple of ways.
Oh, how so?
Well, you have what we call IgE-mediated reactions. These are your kind of classic rapid allergies. Think hives or urticaria, swelling of the lips or tongue, angioedema, we call it, maybe itching in the mouth.
Right, the quick stuff.
Yeah, typically pops up very quickly, often within 2 hours of consuming those milk proteins.
Okay, and the other way.
But then you have non-IgE-mediated reactions. Now, these develop much, much later, anywhere from, say, 2 to 48 hours, or sometimes even a few days after ingestion.
Wow, days later.
Yeah. And it's really important to note here that these non-IgE-mediated CMA symptoms are frequently mislabeled as just simple intolerance.
Okay, so that adds to the confusion we talked about.
Big time. Adds to that widespread confusion.
So that fundamental difference in mechanism and enzyme deficiency, basically a digestive issue, versus an immune system really throwing a full-on reaction to a protein, that is absolutely key.
It's foundational. Understanding that unlocks everything else.
Okay, now let's really deep dive into lactose intolerance specifically then. What exactly is lactose, and what is this lactase enzyme supposed to be doing?
Right. So lactose is a disaccharide, fancy word, but it just means it's a type of sugar made up of two simpler sugars, galactose and glucose. And it's naturally found in milk. Now, your body has an enzyme called lactase. You might sometimes hear it called beta-galactosidase.
Let's stick with lactase. Easier.
Yeah, lactase is fine. Its job is basically to act like tiny scissors in the lining, the brush border of your small intestine.
Okay.
It snips that lactose molecule, breaking it down into glucose and galactose.
And then those get absorbed.
Exactly. They get easily absorbed into your bloodstream. But here's what happens if lactase is deficient. That undigested lactose keeps traveling all the way down to your large intestine.
Okay, so it escapes the small intestine.
Right. And once it's there, it acts like a magnet. It starts pulling water into your gut through osmosis.
Hence the watery issues.
That causes a lot of the uncomfortable symptoms, yes. Plus, your gut bacteria, they're always busy down there.
Yeah.
They start fermenting this undigested lactose. And that fermentation process produces gases, hydrogen, methane, carbon dioxide, and also some volatile fatty acids.
So that's the bloating and the gas people feel.
That's exactly it. All of these contribute significantly to the discomfort.
Got it. So it's not just one type of lactase deficiency then. You're saying there are different reasons why someone might be lactose intolerant. That's really interesting.
That's absolutely right. There are 3 main types based on what causes the lactase deficiency.
Okay, what are they?
First, there's congenital lactase deficiency, CLD. This one is incredibly rare.
Okay.
It's an autosomal recessive genetic condition. Basically, the lactase enzyme is either completely absent or severely reduced right from birth.
Wow, from birth?
Yeah. Symptoms are pretty dramatic, starting in the first few days of life when an infant has breast milk or any lactose-containing formula. Think severe watery diarrhea, lots of gas, bloating, what we call intestinal meteorism,
Oh, dear.
and malnutrition. The good news is these symptoms disappear immediately if baby goes on to a completely lactose-free diet. It's mainly described in Finland, actually, due to something called a founder effect.
Fascinating. Okay, so that's the rare one. What's next?
Then we have primary lactose intolerance. This is also called adult-type lactase deficiency.
Right.
And this is by far the most common type globally. It's a genetically determined condition where your body simply starts producing less lactase, usually later in childhood or adolescence.
So it's programmed to happen for many people.
Pretty much. It's actually the norm, statistically speaking. About 70% of the global adult population becomes lactase non-persistent, meaning their lactase levels drop.
70%, that's huge.
It is. And the age it starts varies a lot by ethnicity. For individuals of African, Asian, or Hispanic descent, symptoms might show up between ages 2 and 3.
That early?
Can be. Whereas for those of European and American descent, it typically happens later, maybe around 5 to 6 years old, or even during adolescence.
Huh. Okay, so that's primary. What's the third type?
And the third type is secondary lactase deficiency. Now, this one is transient.
Meaning temporary.
Yes, temporary. It results from damage to the small intestine itself.
Ah, so something else causes it.
Exactly. So think about conditions like viral gastroenteritis, a bad stomach bug,
Yeah.
or infections like giardiasis, untreated celiac disease, or even, and here's a really key connection we need to remember.
What's that?
Cow's milk allergy itself can cause severe gut damage, what we call enteropathy,
Right.
that then leads to the secondary temporary lactase deficiency. Other causes could be small bowel bacterial overgrowth, Crohn's disease, even radiation or chemotherapy.
Wow. So the allergy can cause the intolerance temporarily.
Precisely. But the great news with secondary lactase deficiency is that once you treat the underlying condition and the gut heals, lactase levels can often be restored and those symptoms go away.
That makes so much sense. It really underlines why getting to the root cause, the real problem, is so vital.
Absolutely.
And just to briefly touch on it, you mentioned there's also something called developmental lactase deficiency.
Yeah, that's sometimes seen in premature infants. Their gut just isn't fully developed yet, particularly the enterocytes that produce lactase, which develop later in the 3rd trimester, so their lactase levels are reduced.
That gets better.
Thankfully, yes, this is typically a transient issue that improves as they mature.
Okay. So, with that deep understanding of the mechanisms, let's talk symptoms. What do these differences actually feel like for someone?
Right. Well, for lactose intolerance, those symptoms typically kick in within, say, 30 minutes to maybe 2 hours after you consume something with lactose.
Okay, relatively quick.
Yeah. And you'll generally experience those gastrointestinal issues we talked about. Abdominal pain, often kind of a generalized discomfort, not in one specific spot, along with bloating, increased gas flatulence, nausea, maybe increased gut motility, things moving faster,
Right.
and often that osmotic diarrhea, the watery kind. Less commonly, some people might actually get constipation or even vomit.
Okay, mostly gut stuff. But you mentioned something else earlier.
Yes. And this is really fascinating and maybe surprising to some listeners. Up to 20% of people with carbohydrate intolerance, including LI, also report extraintestinal symptoms.
Outside the gut. Like what?
Things like headache, vertigo, even memory impairment and lethargy, just feeling really wiped out.
Wow, headaches and memory issues from lactose. That's genuinely surprising.
Well, this raises an important question, doesn't it? The speculation is that these could be due to maybe toxic metabolites produced by that sugar fermentation down in your colon.
Ah, the bacteria byproducts.
Exactly. Potentially altering cell signaling pathways, but, more research is definitely needed there. It highlights just how complex our gut-brain connection is.
Absolutely. So how do those symptoms stack up against what we see with the cow's milk allergy? Is there like a clear difference someone could feel?
That's a great question. And the picture with cow's milk allergy is often much more severe, potentially, and distinct, especially depending on the type of immune reaction, that IgE or non-IgE we mentioned. For the Ig-mediated CMA, the symptoms are typically very rapid and can be quite alarming.
Right.
You'll see things like that, quick onset hives, urticaria, swelling around the lips, tongue, palate, that angioedema, itching inside the mouth, oral pruritus, maybe severe colicky abdominal pain, vomiting, diarrhea.
Okay, so some overlap with gut stuff, but also these other signs.
Yes, and potentially more systemic signs too, like respiratory issues, cough, wheezing, shortness of breath, widespread skin reactions, or even, in the worst cases, life-threatening anaphylaxis.
Okay, that's clearly very different and serious. What about the non-IgE type? The slower one.
Right. The non-IgE-mediated CMA symptoms, they can be more delayed and often more chronic. Things like persistent vomiting, chronic diarrhea, maybe visible blood and wubrucus in the stools.
A lot of mucus, okay.
Abdominal pain, malabsorption issues leading to poor nutrient uptake, and often, especially in children, what we call failure to thrive or just poor weight gain.
You can definitely see the overlap in some of those gut symptoms, though.
Yeah.
The pain, the diarrhea. That perfectly explains why people get them confused.
It really does.
That must make diagnosis a real challenge sometimes.
It absolutely does. Persistent diarrhea, that perianal rash or irritation you might see on a baby's bottom, often due to very acidic stools from fermentation.
Right.
And poor weight gain. Unfortunately, those can be common to both conditions if they're left untreated. And remember that connection, CMA itself can cause secondary lactase deficiency because of the intestinal damage.
Right, adding another layer of complexity.
Exactly. So if you're experiencing these symptoms, what does this all mean for actually figuring out what's really going on in your body?
This brings us right to the critical step. Getting an accurate diagnosis. It feels so important to get this right. Avoid unnecessary dietary restrictions, or worse, miss a serious diagnosis.
Absolutely critical.
And delay the proper treatment.
Couldn't agree more. So, for primary lactose intolerance, the lactose breath test, or LBT, is currently the mainstay, the gold standard.
The breath test. Okay. Yeah. How does that work?
It's actually pretty neat. It's rapid. It's non-invasive. Essentially, we measure the hydrogen and often methane to content in your exhaled air.
From your breath.
From your breath, exactly. After you've consumed a controlled dose of lactose. For adults, it's typically 25 grams, which is roughly the amount in, say, 2 cups of milk.
Right.
For children, it's weight-based, usually 1 gram per kilogram of body weight.
And the procedure.
Pretty straightforward. You need to fast beforehand, usually 8 to 12 hours, no eating, just water.
Right.
Then you come in, you drink the lactose solution, and then we collect breath samples at regular intervals, usually every 20 minutes or so, for about 2 to 5 hours.
Okay, so it takes a few hours. What are you looking for?
We're looking for a significant rise in hydrogen in your breath compared to your baseline before you drink the lactose.
Hydrogen. From the bacteria.
Exactly. From your gut bacteria fermenting that undigested lactose we talked about. A rise of 20 parts per million, or ppm or more, is generally considered a positive result.
A red flag.
Kind of like a red flag, yeah. Showing your gut bacteria are having a bit of a party down there. We also often measure methane.
Why methane too?
Because some people's gut bacteria produce more methane than hydrogen, or primarily methane. So maybe 10-15% of the population are low or non-hydrogen producers. If you only measured hydrogen, you might miss it. So we look for a rise in methane too, maybe 10 ppm.
Got it. Comprehensive. Are there things that can mess up the test?
Oh, definitely. The pre-test conditions are absolutely critical for accuracy.
Like what?
No antibiotics in the previous 4 weeks. They wipe out gut bacteria.
Makes sense.
No certain medications like prokinetics, which speed up gut transit, or laxatives in the previous 7 days. No highly fermentable foods like beans or high-fiber stuff for 24 hours beforehand. And even things like limiting vigorous physical activity during the test itself. Without sticking to these, you can definitely get false positive or false negative results.
Okay, so preparation is key. What about genetic testing? You mentioned that for the rare type.
Yes, genetic testing is available, especially if we suspect that very rare congenital lactase deficiency looking for specific mutations in the LPH gene.
Right.
It can also tell you more broadly if you have the genetic predisposition for lactase persistence, meaning you keep producing lactase or non-persistence, the common adult type.
But does that mean you have intolerance?
And that's a really important point. No, just having the lactase non-persistent gene doesn't automatically mean you'll have symptoms of lactose intolerance, certainly not right away. Symptoms might appear much later in life, or maybe not significantly. So its clinical usefulness can be a bit controversial because just knowing you have the gene might lead some people to restrict dairy unnecessarily before they even have symptoms.
Right, I see the potential issue there. Are there other tests people might hear about?
Yeah, there are older tests. The lactose tolerance test where they measure your blood glucose after lactose. It's just not very sensitive or specific, often gives false results. It's largely been replaced by the breath tests, the LBT.
Okay.
And simple stool tests looking for reducing sugars or checking pH. They're very indirect, not specific, maybe used sometimes for infants, but generally not recommended for children over 2 because they have a high rate of false negatives.
Okay, so the breath test seems like the way to go for LI. That sounds incredibly precise. How does the diagnostic process for cow's milk allergy compare then? Is it also a breath test or totally different?
Great question. No, the diagnostic path for cow's milk allergy is indeed completely different because remember, we're dealing with the immune system here, not just digestion of a sugar.
Right, the protein trigger.
Exactly. So for those rapid IgE-mediated reactions, we rely on tools like skin prick tests, where tiny amounts of milk protein are introduced to the skin. Also, IgE-specific blood serum tests, looking for those allergy antibodies. And then, crucially, often the definitive test is a medically supervised oral food challenge.
What does that involve?
It means carefully giving tiny, gradually increasing amounts of milk in a controlled environment, like a hospital or clinic, to see if a reaction occurs under close observation.
Okay, very careful. And for the non-IgE type, the delayed one.
That's often more complex to diagnose. It relies heavily on a careful history than typically an elimination diet removing all cow's milk protein for a period, followed by a careful planned reintroduction, again, usually under medical supervision, to see if symptoms reappear. It takes time and careful monitoring.
Wow, okay. Definitely different pathways. So once a diagnosis is finally made, LI or CMA, how does the treatment and management differ? And what are some of those common misconceptions people really need to avoid?
Right. The treatment approach hinges entirely on whether it's an allergy or an intolerance. This is critical.
Okay.
For lactose intolerance, the management focuses on reducing lactose intake, finding your personal threshold. It's usually not about complete exclusion.
That's a really important distinction, not total avoidance.
Yes. Most available data suggest that adolescents and adults with primary LI can often handle up to 12 grams of lactose in a single dose. That's about what's in 1 cup or 240 milliliters of milk with minimal or even no symptoms.
Okay, so finding your limit.
Exactly. So for primary LI, a good approach is maybe a strict low lactose diet for 2 to 4 weeks just to get symptoms completely under control, let things calm down. Then you gradually reintroduce lactose-containing foods to figure out your personal tolerance level. How much can you handle without symptoms?
Personalized approach.
Very much so. Now, if it's secondary LI, remember the temporary kind.
Yeah, caused by something else.
Right. Then that restricted diet is only necessary for a limited time, usually, until the underlying condition, the gut infection, the celiac disease, whatever it was, resolves and the gut heals.
Makes sense.
Only for that very, very rare congenital lactase deficiency is a complete lifelong strict lactose-free diet required.
Got it. Okay, that's LI. What about CMA? Cow's milk allergy.
Totally different ballgame. For cow's milk allergy, it is about strict avoidance. Complete avoidance of all cow's milk-derived allergenic proteins.
No finding a threshold there.
No. Even tiny trace amounts of the protein can trigger significant symptoms, especially in highly sensitive individuals. So it requires careful label reading, avoiding cross-contamination, a much stricter approach.
That's a huge difference. Reducing versus strict avoidance. Are there any other ways to manage lactose intolerance besides just limiting intake? And what about nutrition? If you cut back on dairy?
Good questions. Yes, there are other approaches for LI. Enzyme replacement is one option.
Taking lactase pills.
Exactly. You can take oral lactase supplements, those beta-galactosidase enzymes, usually right before you eat or drink something with lactose.
Do they work?
Preliminary data show they can improve symptoms and decrease that hydrogen production on breath tests. However, more robust data is probably needed. And one issue is that ingested lactase can be broken down by stomach acid. So its efficacy might depend on the specific formulation, maybe enteric coating, or how it's taken. Sometimes adding it to milk or formula hours before consuming helps.
Okay. What else?
Probiotics and prebiotics are also showing some promise.
The gut bacteria helpers.
Right. Some studies suggest certain probiotic combinations, for example, Lactobacillus casei shirota and Bifidobacterium brevi might improve symptoms and reduce hydrogen production.
Interesting.
And consuming certain prebiotic fibers like short-chain galactoligosaccharides, or GOS, has also shown potential, likely by positively modifying the gut microbiota, feeding the good bugs.
So manipulating the gut environment could help.
It seems possible, and this really raises an important question, doesn't it? Are we maybe seeing a future where personalized microbiome approaches could help manage these conditions much better? It's an exciting area of research.
Definitely food for thought. Anything else on management?
Just one more point. It's worth noting that sometimes lactose intolerance isn't isolated. It can be part of a wider intolerance to a group of short-chain carbohydrates we call FODMAPs.
FODMAPs, I've heard of those.
Yeah, it stands for fermentable oligo, monosaccharides, and polyols. Lactose is the D in FODMAPs. This overlap is especially common in people who also have irritable bowel syndrome, IBS.
Oh.
So for those individuals, sometimes just reducing lactose isn't enough, and a broader low FODM mammoth diet might be needed under guidance.
Got it. It seems like lactose-free and dairy-free products are absolutely everywhere now. It's a huge trend.
It really is.
What are some of the misconceptions maybe driving this? And what could be the downside of all these people cutting out dairy unnecessarily?
You're right. The trend of avoiding lactose or dairy altogether, often driven by just perceived intolerance or maybe self-diagnosed allergy, is incredibly widespread. However, these unfounded concerns, they frequently lead to unnecessary milk restriction. And unfortunately, that can have real adverse nutritional outcomes.
Like what kind of outcomes?
This is a really important insight. Cutting out dairy without proper reason or replacement can result in significantly reduced calcium and vitamin D intake.
Key nutrient.
Absolutely. And that can lead to serious issues like nutritional rickets in young children or potentially low bone mineral density and an increased risk of fractures later in life for adults.
Wow. But can people with LI absorb calcium?
Yes, and this is crucial. Calcium absorption itself in individuals with diagnosed lactose intolerance is typically normal. They just can't digest the sugar lactose efficiently.
Right.
So the calcium is still absorbable. They just might need to get it from lactose-free milk, fortified alternatives, or other non-dairy food sources or supplements if needed. The issue isn't absorption, it's avoidance of the food group.
Got it. Any other common misconceptions?
Yeah, a big one, especially for parents.
Yeah.
Infantile colic. It is generally not caused by lactose intolerance, and using lactose-free formula is typically ineffective for treating standard colic.
Good to know.
And what's truly concerning, going back to this confusion between CMA and LI, it isn't just about mild discomfort sometimes.
Yeah.
It can actually delay the proper diagnosis for severe conditions like cow's milk allergy. And that delay can mean missed nutritional needs, prolonged suffering, especially for infants and children.
That's serious.
It really is. That's why getting this distinction right is literally life-changing for some families. And it highlights why proper education, both for the public and for healthcare providers, is so absolutely crucial.
Definitely.
Interestingly, just one final point on this. Even in extensively hydrolyzed formulas, EHFs.
Those are the special formulas for babies with CM, right?
Yeah.
Highly broken down protein.
Exactly. Even though the protein is broken down, they often still contain lactose. And research suggests this lactose can actually have beneficial prebiotic effects in these infants.
Really?
It seems to help increase the good gut bacteria, like bifidobacteria, and also beneficial short-chain fatty acids. This might positively influence their early immune system development.
Wow.
And maybe potentially even help some of these infants develop tolerance to milk over time. So lactose isn't always the enemy, even in this context.
That's a truly powerful point and kind of counterintuitive. So, okay, bring it all back home then.
Yeah.
The big takeaway seems to be lactose intolerance and cow's milk allergy are fundamentally different conditions. Full stop.
Absolutely.
Even though they might sometimes share overlapping symptoms, especially gut symptoms. One is about an enzyme not breaking down a sugar.
Right. Non-immune.
And the other is about your immune system having a full-blown reaction to a protein.
Immune-mediated, yep.
And getting that distinction right feels paramount.
It truly is. The importance of an accurate diagnosis using the right tools, like that lactose breath test for LI, or the allergy testing for CMA, and then getting tailored management based on the correct diagnosis, it just cannot be overstated.
Yeah.
It avoids those unnecessary dietary restrictions we talked about, ensures you get optimal nutrition, and prevents dangerous delays in treating more serious conditions like CMA. It really connects to that bigger picture of, critical thinking in your own health. Truly understanding the why behind what you're experiencing is absolutely paramount to making good health decisions.
Well said. Thank you for joining us for this deep dive today. We really hope you listening feel much more well-informed now and empowered to be a truly knowledgeable consumer of health information.
That's so too.
And just as a final thought to leave you with, if our understanding of the gut microbiota and our genetics continues to advance at the pace it is, just imagine how much more personalized our diets might become in the future, moving beyond these broad dietary restrictions to truly precise individual nutritional strategies for everyone. Wouldn't that be something?